But just want to go over some of the key topics and some of the things we see with regularity and just give you a bit of a description on those. And I'll try to whip through it pretty quick, so if you guys have any questions at the end, I can answer it. This is a talk that's a lot different than it was a decade or 15 years ago, because we have a lot of new toys and techniques that we didn't have then. And there'll be a few of those pictures in here today. In general, vascular disease just refers to a blood vessel problem, and those are arteries or veins. Arteries take blood away from the heart, veins return blood to the heart. So there's two circuits that are involved. The problems with the arteries are generally the much more severe issues, and most of the time that regards to buildup of plaque or blockages in the artery, although we'll talk a little bit about aneurysms or enlargements of the arteries as well. The artery problems are definitely when you have more life and limb-threatening problems, but venous disease is also very common and can cause a lot of pain and difficulties as well. When you have vein problems, you can have blood clots, and that's what you hear about after surgery, things like that. And those are the more serious of the problems and the ones that are treated with blood thinners and sometimes some other procedures. But actually the most common of all these problems are leaky vein valves in the legs causing venous insufficiency. It's associated with varicose veins, which many people either have or know people who do have. And we treat those with different types of ablation and injection procedures in the office, as well as some other things from time to time. In brief, artery disease can be separated largely into two major things. There are some other issues, but blockages can happen in any artery in the body. But several areas are much more affected, and those are the ones I'm going to touch on today. And blockages are basically a buildup of plaque, calcium, and other aggregates that narrow the artery. Aneurysms are kind of the opposite. They're an enlargement of the artery. They're an artery that has become too large and can cause problems, in particular with rupture or leakage of blood, which can be immediately life-threatening. And on occasion, they can build up clots within the aneurysms as well that can be problematic. And again, we're going to go over some of the areas a little bit head to toe on some of our major vascular issues. Carotid artery disease refers to blockage in the neck arteries. The carotid arteries are the main arteries to the brain. They provide about 90 to 95% of the blood flow to the brain. You have one on each side. There are a couple of other arteries that also go to the brain, but they're much smaller and not generally treated with surgery, stenting, things like that. The risks are mainly of stroke or loss of vision. The carotid arteries provide the blood flow to the eye as well as the brain. And that's the reason for treating, to avoid or prevent stroke or reduce the risk of stroke. Blockages of 70% or less are generally treated with medicines to help stabilize the plaque. And when you say medicine, it's cholesterol medicines, aspirin, Plavix, things of that nature. There's some newer drugs out on the market as well that are effective in thinning the blood and helping keeping the blood products from sticking to the plaque or building up. Blockages of 75% or more are considered for surgery or stenting, and we'll go through that a little bit in more detail. The surgery for carotid arteries is called carotid endarterectomy. It's the traditional surgical method. It's tried and true. It's been around for 40 or 50 years now. It generally involves about a 2-inch incision in front of the muscle of the neck, and you go in and you get above and below the plaque and clean out the plaque. It's a durable operation. It's a safe operation with a less than 5% risk of complications, but it's still major surgery, and you're still clamping off the arteries to the brain. There's small risks of heart attack, stroke, bleeding, infection, as with many surgeries. But most folks who have it done are out of the hospital in 24 hours. It's an overnight stay in a monitored unit like the critical care unit, and then home the next day. And I'm afraid this picture won't come across real well, but basically, let's see if I can figure out the pointer on here, but maybe not. The incision is made right on top of the plaque. You clean out the plaque, which the kind of middle picture there is. It shells out much like that. It is basically a cast of plaque, so it's usually hard, and then you close the artery up with sutures and usually a little patch to open the artery. And it has been shown for blockages of 75% or more to significantly reduce the risk of stroke, and that's in tens of thousands of patients in studies in both Europe and America. So it's a tried and true method, and one we do frequently. It's something we do at least several times a month nowadays. Another option exists that didn't exist. Oops, I may have paused it accidentally. 20 years or so ago, and it's only in the last 10 to 12 years that it's really come to being acceptable treatment for carotid artery disease, and that's stenting. That basically opens the carotid artery without an incision. It's done similar to a heart catheterization, and we're going to say that several times today because a lot of the procedures we do now for vascular disease just involve a puncture in the groin, and we pass a catheter to wherever in the body we are going. It is generally used for higher risk patients who can't have surgery, cannot go through anesthesia, really bad heart, really bad lungs. It's also a very good technique for blockages that have come back years and years later after it's been cleaned out before. And those are probably the most common times we do it. We also do it for blockages that are too high to get to with surgery, for folks who've had radiation on their neck from cancer, for folks with tracheostomies. Those are the common reasons we would do a stent rather than open surgery. On the average patient, we're still going to do open surgery because it has a lower risk of stroke. There's a higher risk of stroke with carotid artery stenting, but it does lower the risk of heart attack and medical complications, so to speak, with the procedure. And it is also a 24-hour hospital stay. So there's not a significant decrease in downtime and recovery. You have to cross the plaque or cross the narrowed area to get the stent in, and that's why strokes can happen, whereas with surgery you can clamp above the blockage, protect the brain, and so there is always probably going to be a slightly higher risk of stroke with stenting than there is with open surgery. This is a schematic kind of showing a stepwise progression. The big chunk out of the artery that is on the far picture, the picture nearest me, is the plaque, and that's actually a pretty typical appearance of what a plaque at the carotid artery looks like. And as you go across, we've put a stent in and then ballooned the stent, and as you can see, the blood flow is much smoother and much better than it was before the stent was placed. So stenting has become a technique that we are using probably about 20% of the time, and surgery about 80% of the time. We probably do 15 to 20 of these a year, and we're going to do anywhere from 60 to 80 open carotid surgeries a year. We do between 75 and 100 carotid artery interventions here at Alamance each year. The next topic we're going to touch on is aortic aneurysms, and aneurysm is a scary term. Probably everybody in here has heard of it or knows somebody that's had one. You can have an aneurysm in multiple blood vessels in the body, but the most common and the most life-threatening are in the aorta, which is the main artery that runs from the heart down to the leg arteries. It splits at the pelvis and goes to your leg arteries. If it ruptures or bursts, that's generally fatal. Most folks do not make it to the hospital if that happens. And that is why we generally fix them before they're going to do that. They can occur in the chest, which is called a thoracic aneurysm, or they can occur in the abdomen or belly, which is the abdominal aortic aneurysm. The abdominal aortic aneurysm, or AAA, is much more common. It's probably 9 to 1, and also much more common in men. Women only involve about 10 to 15% of AAAs. In general, they cause no symptoms until they rupture or until they are at a size where they are now very large and compressing on things and at risk of rupture. The risk of rupture in the chest at less than 6 centimeters is less than 1% per year. And in the abdomen, it's 5 centimeters is less than 1% per year. So we do not fix them until they reach that size. Once they reach that size, we consider them for repair. This is just a schematic kind of showing the bulge. The top far picture is, if it's in the chest, it's a thoracic aortic aneurysm. And if it starts down in the belly at the level of the kidney arteries or below, it's an abdominal aortic aneurysm. And that is the main pipe. That's the main artery that runs from the heart and is the tree trunk, so to speak, that supplies every other artery in the body. the reason to fix it is to avoid rupture. Again, they don't cause symptoms, so we're not fixing it to improve pain, or we're not fixing it to do anything in specific, but it's to avoid rupture. The majority nowadays are fixed with what's called a stent graft, and that is a covered tube, a chicken wire tube that is covered with multiple layers of PTFE or Gore-Tex, like a raincoat. That excludes the aneurysm from flow and reduces the risk of rupture. This is also a 24-hour hospital stay. Most folks who have these done will go home the next day. It's durable. Initially, when this procedure first came out about 18 to 20 years ago, the first one was done after a surgeon in Brazil made one in his garage and put it in a patient. And it worked. So, it is. And obviously in America, you go through the FDA. It took a little longer than that. So, but the technique was, Juan Perotti was clearly an innovator and figured out a safer way to fix aneurysms, because open surgery is a much larger undertaking. It has about a 4 to 5% chance of not surviving 30 days past the operation. We still do those, and we have some patients we have to do them on, but it is a major undertaking with a 3 to 4 month recovery. And so if the anatomy is acceptable, meaning we can do it without harming the kidney arteries or without harming the intestine arteries, we're generally going to fix the aneurysm with a stent graft. This is kind of a brief schematic showing a stepwise progression, and what you have is the bulge in the artery, or the aortic aneurysm. We go in through the groin arteries, much like we're going to talk about with a lot of procedures. The femoral artery is our access site. With these devices, we do generally make a small cut, although it can be done with just a needle puncture as well. The delivery system is taken up to just below the kidney arteries and then deployed. And it looks like a pair of pants with one long leg and one short leg, and then the other leg is brought up from the other side, so you access both femoral arteries to repair an aneurysm this way. These procedures tend to take about an hour and a half or so, and can be done with spinal anesthesia or a heavy sedative, but most of the time it is under general anesthesia. And again, the risks of not making it through this operation are less than 1 out of 100. There are complications, but they're small as compared to the open operation, which is a 4 or 5% chance of not making it through. Most folks get through the surgery, but not making it out of the hospital. Kind of a corollary to abdominal aortic aneurysms, the kidney arteries, which you guys can see just above the aneurysms, are a common place that plaque builds up and causes blockage, and it's called renal artery disease. The result of that is usually very difficult to control blood pressure. Most people who have high blood pressure just have high blood pressure, but some individuals it's because of a blockage to the kidney artery. And if that progresses, it can lead to renal failure and need for dialysis, which we're going to talk about a little bit later. If it's mild, if it's early, most are treated well with medicines. In later stages, if medicines aren't working, we in general will put a stent across the blockage to open up the blockage and improve the blood flow to the kidney. Doesn't necessarily reverse the damage that has been done already to that kidney, but it helps keep it from progressing and saves that kidney function. It also improves the blood pressure. It's generally an outpatient procedure. Some individuals do stay overnight. It's done with just the needle puncture, not a cut. And there are occasions where the blockage is either too extensive, too far out the artery, or other mitigating factors that require a bypass surgery around the blockage, but that's not common these days. That's something that probably 97, 98% of the time we're going to be able to fix it with a stent and not need bypass surgery. And this is kind of a stepwise progression, similar to on the aneurysm screen, getting up to the kidney arteries, getting out to the renal arteries, or the kind of the T, or the cross of the T there. You get a catheter out there, you pass a wire beyond the blockage, you balloon the blockage to get the stent in, and then you deploy a stent. And the far bottom picture is post-stent deployment. The stent basically encompasses the first part of the artery and holds that artery open to trap the plaque and open the blood flow to that kidney. Kind of working our way down to peripheral artery disease. Now this is actually, of all the things we're going to discuss today, this is the most common artery problem. And what this refers to is blockages in the leg artery, anywhere from the pelvis down. It causes pain in the legs with activity. At first, it causes no symptoms in the very mild or early stages. The next step is your legs start to tire with walking. In particular, the muscles start cramping because the muscles aren't getting enough blood flow with activity. Generally at rest, the blood flow is adequate, but with activity, the muscles need more blood. And if they're not getting it, it causes pain. They're basically crying out for more blood. It does not usually cause pain at rest until it's very severe and very late. And so if you're sitting and your leg hurts, it's probably not PAD. It's when you get up and walk and you start cramping in your muscles that we start thinking about PAD. The arteries that go down, this kind of just gives you a named artery working your way down the leg. The iliac is the pelvis artery. The common femoral artery is the artery in the groin where we go in to do a lot of our procedures. The superficial femoral artery is the thigh artery, and that's actually the most common site of the blockages. The popliteal artery is the knee, right around the knee. And then the tibial arteries are down in the calf, with the perineal being the third of those three. And the small cutout is just showing how the plaque builds up and blocks those arteries. And that is the same process that affects the carotid arteries, affects the kidney arteries. It's plaque, it's cholesterol deposits, calcium. What causes that plaque? There's a variety of things. Smoking is probably the worst causative factor. And even a history of smoking can lead to damage years later, even if you stop. High blood pressure, high cholesterol, diabetes, all certainly play into the buildup of plaque. Family history has something to do with it, and age actually has something to do with it. Even if we're very healthy, don't have a lot of medical problems, as we get older, there's some calcium deposition and plaque deposition at areas of turbulence, at areas of splitting of the artery. And so, what can we do to avoid that? Well, don't smoke. If you have high blood pressure, control it. If you have cholesterol, the cholesterol medicines, the statin medicines are very good at lowering cholesterol and reducing the plaque. Diabetes is obviously all about sugar control, and we've learned over the last decade or so that tight sugar control is probably the most important thing to avoid complications of diabetes. Not much we can do about age. We're all, hopefully going to get older, and that's just something we have to watch for with time. And you can't change your parents either. If you have a strong family history, think about it. If mom had a stroke and dad had a heart attack, it's something to think about because you are at risk of developing things as time goes on. Treatment options for peripheral arterial disease. One of the things, even if we do interventions or procedures, we recommend stopping smoking, getting on an exercise program to help build up blood flow around the blockages called collateral blood vessels. And so those are very important even if we go on to do invasive therapy. But conservative therapy is always recommended, and if it's mild, that's all we will do. If it's early stages, that's all we'll recommend. The next step, if it's severe, refractory to conservative therapy, is to do what are called arteriograms or angiograms, which is a little bit of what we've talked about with a lot of the other ones. We go in through the groin artery, we take pictures with X-ray dye, we cross the blockages, then we open them up with angioplasty, and in some locations stents as well. Some locations angioplasty alone. We have some other techniques where we have for lack of a better term, a roto-rooter to clean out the arteries. We have some other devices that help us cross blockages. We have a lot more toys than we did 15 or 20 years ago, and arteriograms were not really treatments for peripheral arterial disease 15 years ago. They just took pictures, and then we did bypass surgeries. Bypass surgeries for leg artery blockages are much less common, but still done, and if in severe cases sometimes need to be done. If someone has an ulcer that won't heal and we can't open it up with balloons and stents, they probably need a bypass, or they might lose their leg. It is a serious problem, and that's just an angiogram picture. The black is the dye with the arteries. On my side is a picture before a stent, and on the other side is a picture after the stent. I think everybody can see the napkin ring blockage with the arrow, and then after the stent it's opened up and the blood flow is returned to normal literally in an instant, and the legs generally feel better immediately. It is, this procedure, a procedure like this is literally like a 30 or 40-minute procedure, and you can feel better right away. This is a bit of a schematic of how you would do a bypass graft if there's a blockage that you can't get across. Basically, you use either a person's own vein, the saphenous vein, just like with the heart, or a PTFE tube to go around the blockage, go above and below the blockage, and sew that in. Obviously, with a large surgical incision, it's a lot more involved. This is a 3 to 4 day hospital stay, and there's higher risks of heart problems, pneumonias, infections, things like that, because you've been put through surgery with anesthesia. But it is still an option for some individuals. I'm going to talk a little bit about venous problems, and the first is deep venous thrombosis or pulmonary embolus, and those are blood clots. When you hear about somebody getting a blood clot after surgery or after a trauma, that's probably what it was. When it's in the legs, it's called deep venous thrombosis. And they can happen in the arms, but it's much less common. If the clots break off from the legs and travel to the heart and lungs, that's called a pulmonary embolus, and that's life-threatening. It's one of the top 10 causes of death in America. These are generally treated with blood thinners for anywhere from 6 to 12 months. And in some individuals for life if they have a genetic predisposition to developing clots. The risk factors for this are recent trauma, recent surgery, immobility, somebody who's laid up in the bed for weeks after surgery, after an injury, or even after just a bad medical illness is at risk of getting those. And some individuals, up to 3 to 4% of the population, have some genetic predisposition to clots. So if mom had blood clots or dad had blood clots, it's something to think about. Does it mean you have to have them? No. But it is a situation where there is a genetic predisposition in a small portion of the population. This is a picture of kind of an old open thrombectomy, and that jelly that comes out looks something like that. It literally looks like a thick jelly, and it is, if that goes to the the pulmonary artery or the lungs, that clogs it up and stops the blood flow and puts folks into heart failure. And so it used to be we would actually go in, make an incision, and pull that clot out. Now we go in with catheters, bust up the clot, and suck it out. So a little bit different technique, but that's a good picture showing it's pretty nasty stuff. Blood clots are not something that probably everybody wants to see at lunchtime. But the more common problem when we talk about veins, but less severe, so to speak, is called venous insufficiency. And this is where you're talking about the leaky veins, leaky vein valves in the legs. This is associated with varicose veins. If somebody has very large varicosities, that is usually associated to leaky valves causing blood to pool in the lower legs. Causes swelling in the legs, causes heaviness, tiredness, and outright pain in the legs in some individuals. It's a very common problem, and one of the times we see it most is in women after pregnancy. All that pressure on the pelvis veins for 9 months disrupts the vein valves, and women are more prone to this than men, although men get it as well. Up to 50% of women have some degree of this. It can be very mild, it can be very severe, and some folks it can be very debilitating. The conservative treatments include compression stockings, which everybody remembers being the ugly socks basically, and they're still not pretty, but they're a little nicer now than they used to be. They are tighter at the toe than they are at the calf or the thigh, and they're graduated such that blood flow is promoted rather than constricted. Leg elevation is important. At the end of the day, propping the legs up. And anti-inflammatories such as naproxen or ibuprofen are pretty good at helping alleviate some of the inflammation, but at times it's very severe. And in individuals who have pain and swelling after we've done all the conservative therapies, really tried them, we have some invasive options. 15 to 20 years ago, our only good options were surgery to strip out the veins. You'd have a hospital stay, 15 or 20 incisions on the leg, pull out the veins, a lot of bruising, fairly painful procedure. It was effective, but it was not minimally invasive. And nowadays, most of our procedures are done in the office. And when I say most, probably about 99.5%. It's rare. It's been several years since I've done a vein stripping operation. It's not something we do very often. And the laser or radiofrequency ablation closes off the vein in the office without, again, having to make an incision. Those are generally anywhere from 15 to 30-minute procedures. Obviously, it's an outpatient. Folks are back to work usually in 2 to 3 days. There is some bruising and soreness afterwards. It's not a pain-free procedure by any stretch of the imagination, but as compared to the older open surgery, it's definitely a less invasive option and an equally effective option when we look at the data. For the more superficial veins, we will do injections called sclerotherapy, and that's anything from a spider vein to some of the bigger bulbous veins, and we have some different types of agents that we inject to get rid of the local veins. All those things are done in the office. All those things are very common procedures, something that we do many, many times a week at the office. One of the last things I wanted to talk about, because it's becoming a more common problem, is people with kidney failure on dialysis. It's an ever-growing population in America for multiple reasons. We're an aging population. The two most common causes are high blood pressure and diabetes, and those are common problems. And dialysis has gotten a lot better, so people live many years on dialysis. It used to be people didn't live beyond 3 to 5 years on dialysis. I have lots of patients 20+ years now on dialysis, and part of that is the treatments are better, and part of it is that people are more aware, and we have kidney transplants, we have a lot of other options that exist for patients with renal failure, but it is a growing population. In general, 2 types of dialysis exist. One is called peritoneal dialysis, and what that is we put a catheter into the belly or the pelvis, and you exchange fluid on a nightly basis. And most folks put several liters of fluid in at night. They go to sleep. In the morning, they drain the fluid off. That requires a tube that's placed in the lower abdomen with a short surgical procedure. And basically, the catheter comes out the side, is under a dressing. Most folks, you would never know they have it. If they went swimming or took the shirt off, yes, there is a catheter that exits there, but it's a small plastic tube, usually only a few inches stick out of the body, and it's pretty well hidden. This allows people to continue to work, lead normal day-to-day lives, and do this at night. It is not the most common way we do dialysis. Only about 15% of the population do dialysis this way, but it's an effective way to do dialysis. The more common way we do dialysis is called hemodialysis, and that's a rapid exchange of blood flow through a machine. It's a lot bigger than this box. They're very large machines. Basically, the blood is coming out, going through the machine, getting rid of the toxins, the electrolytes that are dangerous, and then refunneling it into the body. So it's basically taking the place of what the kidneys do with every heartbeat. Most folks go 4 hours a day, 3 times a week. There are individuals that do this at home. They do it for maybe 2 hours a day, every day. But it takes a lot of help at home, and they make smaller boxes for home, but it's still, there's some limitations. The vast majority of people do this at a center. In general, there are 3 ways to do hemodialysis. A catheter, much like the one that we stick in the tummy, is stuck directly into one of the veins, either the jugular vein or the femoral vein, to be a large IV. It's a good short-term option. It can be used immediately, but it's not something you're going to want to leave in as a permanent option because they get infected. They scar the veins if they're in too long. And in general, we try to get those out in less than 100 days. That's our goal when we put one in. That doesn't always happen, but that's what we're trying to do. The 2 main ways we do permanent dialysis or long-term dialysis are with AV grafts or AV fistulas. And what that is arteriovenous graft or arteriovenous fistula. We are connecting the artery and vein circulation. And why would we do that? Well, a vein is not big enough to give the very high flow of blood that they need to exchange dialysis. And so we hook it up to an artery, which is where your blood pressure is. That vein gets bigger, it carries much more blood flow, and now you can stick it with a needle and do those rapid exchanges of fluids. And it's something that If we can, we do a fistula, and what the difference between a fistula and a graft is that we need a superficial vein that's of size that we can connect to the artery and that it will grow to big enough to do that. If you don't have a good vein, and a lot of individuals who've been sick for some time and have burned up all their veins with IVs and lots of things, don't have a vein, we do a graft. And what you're doing there is connecting one of the deep veins, usually up at the shoulder and the upper arm, and an artery with a PTFE or Gore-Tex tube. The downside to a graft is it's a foreign body. Ultimately, you're going to wear it out. The needle punctures it hundreds of times, literally, and eventually it's going to wear out. We know those are only going to last a couple years at best. Whereas a fistula can be a lifelong procedure. That can be the last thing folks ever get. You may require some minor procedures along the way to angioplasty or do problems with strictures in the veins, but it may be the only major access they have to have. And so we try to do a fistula, but a graft is also an acceptable option. This is a schematic kind of showing the difference. That picture doesn't come across real well, but the white plastic tube is the graft, and those needles are where you stick. You have two needles, an in and an out, because you're pulling blood off and returning blood. And you do the same thing with a fistula, which is the far picture, and again, that requires the vein to be dilated, usually 2 to 3 times its normal size by artery blood flow. And that's why when you put in a fistula, you can't use it for about 2 months. A graft you can use in about 2 weeks, and in some instances even sooner if you use a thicker graft. But the graft will not last as long in general. So those are kind of the differences. We do a lot of procedures with needle punctures to treat strictures in the graft, strictures in the veins, problems with the blood flow to help keep these accesses going, because this is a lifeline. If a patient loses their graft or loses their fistula, they have to go back to a catheter and start it at stage 1, and we try to avoid that if at all possible. And we have an ever-growing population of folks on dialysis. I think in Alamance County it's well over 100 now. In Greensboro it's almost 1,000. It is a large number, and actually a lot of the patients from Greensboro come here and we do a lot of their work. We have about 500 or 600 patients on dialysis in our practice that we do these kind of procedures on. And so it's an important thing, and it's, I guess if you're not on dialysis, it's not important to you, but eventually you'll probably know somebody who is. This is a very brief overview of vascular procedures. This is not a comprehensive list. We do a lot of other things with less frequency, but I can't talk to you all day about it. Y'all probably get bored after a while. So we treat bleeding, we treat people who have traumas, we do a lot of other different procedures, but these are some of the more common ones. For a vascular surgeon, basically any blood vessel outside of the heart or the brain is somewhere we should be ready to work on. And I obviously didn't go over all those today, but just wanted to give you a brief overview.